ready for the summer. We all stand and do the happy dance. So we should be able to get through Module 6 pretty easy as far as spinal cord goes. You will see some connections to what we did on the brainstem. I know a little bit of the brainstem started going, and this will be kind of reinforcing some of that. So that would be the intent or the hope. Any questions, concerns, logistics? I mean, I can't believe, we're getting nearer and nearer to the end as far as summer term goes. Business as usual? Business as usual. Okay. Well, last but not least is the discussion of spinal cord. Clinically, probably your biggest clinical concerns, spinal cord injuries, probably the most media attention, followed by maybe some neurodegenerative diseases, anything from or autoimmune from MS or ALS that attack parts of the cord, or less frequent, but does happen out there. I was talking to a friend, she's a PA in an ER setting, and she just innocently had a woman come in with neck pain, and yes, it's kind of statistically it's rare, but she really couldn't get a good handle on it, and they did the imaging, and it turned out she had a cyst in her cervical cord. So you never know, but the spinal cord again is really the big conduit to get to your body as far as execution. We talk about motor function here and doing what we do. That's what the cord is. So before we get there though, we're talking a little bit about the layers of the CNS and also the CSF itself. Clinically again, spinal cord levels, getting in there, doing lumbar punctures, that kind of thing, and assessing from there. So the layers, as we talked about, we've done this before to some degree, different varying degrees. Only want to kind of highlight a little bit of some of the differences up in the brain versus the cord itself. The outside, as we know, dura, arachnoid, pia. I think we've gone through that to at different levels. But what I'd like to talk about a little bit is just comparison as far as the outer inner layer up in the brain. All throughout the whole cord, or the CNS, that dura is a double layer. But up in the brain, it does separate a little bit into two layers, creating those sinuses that we'll chat about as far as venous return from the CNS. Down in the spinal cord, not quite so drastic. It's just a continuation, and that's what you're poking your needle through when you get into that cistern. The arachnoid, its claim to fame will be our discussion as far as CSF and containing the CSF. Clinically, again, a bleed in there, subarachnoid hemorrhage, worst headache of your life is classic clinical SAH. And then last but not least is the PIA, and this saran wrap that follows every little convoluted fold of the CNS really is the last invagination, if you will, of the penetrating blood vessels. We've got a blood-brain barrier here to worry about, and the junction of this as the vessels go through. Eventually, they got to poke through this pia to get into the the actual CNS cellular structure. So looking at it though from the outer layer, as they said, it really is a double layer. There's a layer that adheres right to the skull as far as the dura, and then there's a layer that's really, part of the meninges, or right next to that arachnoid layer, if you will. Beneath that, again, this is where our CSF is floating around, and then again, last but not least, the final layer of the CNS, bless you, is the pia. So when you look at a view like this, it shows you, again, the formation a little bit. The dura forms a couple of things. One, the sinuses that we chatted about, but also these room dividers in the brain. These double folds, we'll look at them in a moment, but the inner layer, the meningeal layer, forms the fox cerebrae and the tentorium that kind of divide, rights and lefts and cerebellum and cerebrum, et cetera, in that skull. But back to our story here, the sinuses are really formed by separation of the endosteal layer of that dura and the meningeal layer, and it forms those big dural sinuses that eventually drain down into your IJV. So we should know them a little bit by name, just looking at them briefly. There's superior, inferior, straight, transverse, and sigmoid. And I'm doing these hand gestures, but really you ought to look at it visually. So this double fold, this fold, the superior really just runs the sagittal region up top, makes sense. And then there's another one that is parallel to it, that's the inferior. All of the CNS is the CSF fluid is draining into these sinuses, if you will. So this is the return of not only of the blood itself that's going through the CNS, capillaries and back, but also the CSF fluid is getting reabsorbed back into these pathways. So all of that fluid eventually is making its merry way down, gets to this piece here, this straight sinus, and then you need to go a little bit more vertical where it comes along the transverse sinus and eventually into the sigmoid sinus that dumps into that jugular foramen that you memorize for your, skulls during anatomy and who dumps into that. And out it goes into the IJV and downstairs to the heart. So this is a drainage system as far as the, skull itself internally, obviously. We did skip through a little bit up near the pituitary. All of these individual sinuses do have, some kind of more specific names. Again, for our purposes, we don't need to go there, but it does play a pretty critical role, too, as far as this drainage that I'll refer to a little bit later on. Bless you again. And this is just highlighting that spot that I was chatting about. So moving on, last before we leave these sinuses, as I said earlier, it obviously drains the capillary mechanism that's going into the brain and out of the brain. But also you have that CSF that's floating around in this subarachnoid space, and eventually that is also getting reabsorbed by these little out pockets of this subarachnoid that's kind of protruding into the sinuses to drain it. So again, that's kind of the overview of circulation in a generic way. So as I said earlier, that inner layer, the meningeal layer, just kind of doubles up on itself to create the room dividers. So the fox cerebrae and cerebelli and tentorium are your big classic. This guy here is a little bit more located near the pituitary. I put a pass on that. The only thing you really ought to just kind of take home from the outline is simply the fox cerebrae is the big one that's separating that right and left hemispheres. Bless you. The tentorium is separating, again, the cerebrum from the cerebellum. And then finally, way down here, there is a little bit of a right and left as far as that cerebellum goes, and the fox cerebelli, obviously named, does the same thing, but on a much smaller scale. So that's, kind of a quick overview as far as those meningeal layers and what they wind up doing as far as formation of sinuses functionally, and then physical room dividers. All right. Potential spaces. Again, epidural, subdural. Again, the outcome on one hand doesn't matter. Either way, if you have any kind of fluid buildup, obviously you're compressing the cerebrum, and next thing you know, you're showing up with all those clinical things we talked about, apraxia or cognitive or whatever the case is going on for whatever region is being, or whatever part of the cortex is getting impacted. But to look at it, this was a nice image just to kind of show you the epidural. technically is a little bit more, again, clinically it doesn't matter, or functionally I shouldn't say. It certainly does as far as the cause and how you get there. But this is more of a arterial side of the fence. We haven't talked too much about circulation in the skull, and we're not really going to, but tends to be more of an arterial bleed versus subdural, where you're more at that level of those venous sinuses, and the venous system that's within this that area tends to be more a venous type of bleed. Again, the outcome functionally doesn't matter. If you have intracranial pressure, you need to address it, identify it, address it, and relieve it. So that's epidural versus subdural as far as hemorrhage. Sneaking down into the spinal cord, as we said, though, if you look at the layers, as far as penetrating, an epidural block, you dump in the anesthesia, and the thought is what it does is just bathe that nerve root as it exits out over it, and that's how you're getting your block, if you will. If you're penetrating and getting into the subarachnoid, you're obviously going through the dura, through the arachnoid, and getting into the CSF fluid. All right. Again, this is imaging, and again, as you can, whether this, I couldn't, you have to read these obviously all day long to be specific, and there probably are, and those of you that have been in the radiology world may have picked up the techniques to be able to differentiate between subdural and epidural as far as a hemorrhage. Obviously, I certainly would look at the film and clearly you can see the, whether it's epidural or subdural, but I couldn't tell you the specific nuances from a film to DDX of the two. All right, subarachnoid space. So we're now going down with more layers. We said CSF. And so we're going to talk a little bit more about CSF in a handful of slides coming up. So I'll not necessarily skim through these, but you get the standard, protects the brain, cushions the brain, sort of gives you a sense it's floating around, even though it does a lot more than that. And we'll talk a little more specifically about circulation and what goes on with ICP, or intracranial pressure. But meanwhile, this subarachnoid space, it's easy to visualize as far as around the brain and then all the way down into the spinal cord. But the caveat is, as you remember, the cord ends at T12, L1-ish, that TL junction, and so you really have a huge space, for lack of a better word, that's known as the cistern. And again, that's the ideal spot. You're sticking the needle in to do your LP. Those nerve roots that are dangling through there, making their way down, can kind of glide out of the way, so to speak, and you're not at risk at trying to stick a needle into the cord. Theoretically, if there wasn't a need, you never would, but to approach from a higher level. Subarachnoid hemorrhage I spoke about earlier. Again, subarachnoid hemorrhage, worst headache I ever felt, is truly, truly the classic. I can count, on one hand the individuals I've interacted with that have experienced an SAH, but the one, usually the academic textbook stuff never translates into the street version clinically of what's going on necessarily, but this is the one time it does. Every single person pretty much almost reiterates this sentence close to a T. So it's a pretty accurate description. And again, when it comes to headaches, head pains, again, your role to triage and DDX on which the continuum the headache actually is from, anything from orthopedic stress type into migraines, clusters, and other patterns, but subarachnoid hemorrhage is probably the first one you want to rule out. But again, it's usually the intensity you certainly can't miss, and there's not too much question. And again, this just gives you a visual as to how a bleed could occur in that subarachnoid space. The arterial blood vessels are making their way through this space, trying to set up, the invagination of the smaller blood vessels to get downstairs and penetrate into the brain. So you have a lot of these, medium-sized to small-sized vessels, arterial vessels going through. And again, at junctions, the aneurysms like to show up. So again, it's often a potential site for SAH type bleed. Okay, CSF. As I said earlier, I'd like to spend a moment. Obviously, clinically, part of your assessment is, a CSF analysis through a LP, et cetera. But I'd like to talk a little bit about the mechanics of it. Again, clinically, we mentioned it in anatomy with the discussion of normal pressure, hydrocephalus, and other, CSF disorders. Anything relating to dysfunction of the flow and pressure can obviously create some CNS impairment. So CSF, what is it? Where is it? Floats around in the ventricles, as I think most of us know. You've looked at these eventually little images, and you see, okay, yeah, we had to memorize what the ventricles are, and so on and so forth. But within the brain and within the spinal cord is this cavity system, ventricular system, that produces and circulates the CSF fluid. Starts up top with the two lateral ventricles. You've got a third ventricle and a fourth ventricle, and then you have connections in between. So we'll kind of run through those. So you've got two lateral ones. These are the ones you see often on the slice at transverse slice of imaging, and you see the little butterfly of a shape, and we talked about, some of you propped them up here with your anatomy presentation about normal pressure hydrocephalus, and they're swollen, or they look like sausages and not the nice contour a ventricle should look like. And then moves into, there's little connections between the two, these foramen Monroe, but eventually land into the third ventricle. Third ventricle has a cerebral aqueduct that drains it into the fourth ventricle. Cerebral aqueduct, we already chatted about, with the discussion about midbrain and dorsal midbrain syndrome and the potential for something to damage that. But eventually, after that fourth ventricle, that CSF has to kind of get outside of this brain and spinal cord, and it exits out a couple little holes, for lack of a better word, in the back of it. There's two kind of lateral ones, and then there's one in the center. So putting it in words is nice, but let's take a little look at what all that really transpires. So when you take the ventricles out, they do the mold, and as we said, everybody's probably seen this before. These are the lateral ventricles. The lateral ventricles are the biggest, and then they have subsets, anterior, posterior horn, all of that. We aren't going to go there, but appreciate that it does exist. Then there's connections down into this third ventricle area. This is that foramen Monroe, those right-left connections that we had chatted about. Then this third ventricle throws it down here to the fourth. So cerebellum sitting here, brainstem sitting here, and that's that cerebral aqueduct that's going between the two. And then eventually below it, the spinal cord continues down, has its central canal, if you will, that allows the CSF to kind of penetrate the cord, and we'll chat about that. It kind of disappears eventually. But the CSF itself eventually exits out into the subarachnoid space, out of this fourth ventricle at the bottom of it. So what does that look like in the big picture? Lateral ventricles. Here's that third. You can barely see the connection of those right-left interventricles, or foramen Monroe, making their way down, and then come down here. There's the aqueduct. Here's the fourth ventricle. And then the continuation down the canal that eventually kind of terminates. Here's just a little different view. I think it's straightforward. Probably the helpful piece of this is appreciating why on imaging sometimes you see different slices. And if the image is kind of, the slice is right through here, you do see the nice, kind of bow tie or butterfly shape of those ventricles. But if the image is cutting across the top and you just see a little, transverse or a little piece of the ventricle, you go, that doesn't look right. Or if the slice is down lower, you catch, a little bit on each horn and you go, oh, that doesn't look right either. So appreciate there's a continuum of your imaging, so you have to make sure, too, you're looking at about the right level to, assess those lateral ventricles as a whole. Okay, and speaking of which, so again, I probably should have plunked this up. So if this was further up, you may just catch the center portion of things, or if it's further down, you may just catch, the posterior and anterior horns, if you will. But clearly, this should make sense as far as anything creating too much pressure. In this case, I just, again, stole it online, is the MPH that we had chatted about, but anything creating a block or poor CSF flow can clearly lead to some kind of congestive problem as far as that's concerned. All right, so thinking of, as far as the flow goes, and CSF itself. What we'll chat about is a little bit about the makeup of it, the function of it, and the pathway of it, I guess. I'm not sure which order the slides go, that's all. And also the other piece of it is what it's actually doing and in terms of its role. And it's kind of a unique scenario because if you think about it, your whole body has this capillary mechanism. You got a blood vessel comes down, makes a capillary. You've got diffusion in and out of that capillary. You've got interstitial space, and then you've got a cell sitting there. Now, the brain has that same mechanism, except for it's got real tight junctions in the capillaries, your blood-brain barrier. So you don't have quite as much exchange. You do, but it's limited, as you know, for a blood-brain barrier. But you also have this added component of the CSF that can also diffuse in throughout the CNS and influence or maintain the homeostasis of that interstitial space. So it's a little unique as far as the hierarchy or the mechanics, I guess, of transcellular flow, if you will, or fluids of the CNS. So as we said, produced in the ventricles. So each of those ventricles, there's a coracoid plexus associated with each, which is a production factory for it. And also some of this CSF is floating, back in, if you will, from the brain itself. And we'll chat about that a little bit later when we talk about the exact flow. But it's contained by the meningeal, and really should just say by the arachnoid layer is what's obviously the bag that it's sitting in, if you will. Sponge for the brain, and what this is really referring to is what I was talking about. Besides the capillary network that's providing fluid and whatever limited nutrients and things that go through that blood-brain barrier, the CSF is doing the same thing. So it's providing fluid, and it's controlled fluid. Obviously, the CSF is a lot different than your plasma and your blood, and it's obviously intended to be controlled for those CNS cells. So it does bathe the brain or the CNS. Fun facts of 2 or 3 pounds of our brains, but if you take out all the H2O, if you will, and put it on the table, there isn't too much left as far as dry weight content. But really the intent there is not these numbers, but more just the concept of that CSF bathing those CNS cells. Again, getting a little bit more visually, that subarachnoid space, it's floating around, but before it gets to there, it's in the whole ventricular system, and then eventually it sneaks out, and it makes its a circulation pattern all the way through the spinal cord, and eventually gets back up, so it's going north to get into those arachnoid villi, or these out pockets of subarachnoid space, if you will. And this is how it winds up getting reabsorbed back into the venous system. With that said, that's your standard neuro textbook explanation, but there are other pathways that I kind of put a couple of talking points in the slide later on about. But this really is your classic pattern, as I said, through the ventricular system, eventually exits out. Those two, you got the Luschka and this median one in the middle down in the bottom of the fourth ventricle, and this is the connection between, the ventricular system and that subarachnoid space. So they're really two different areas, and obviously anything to obstruct or impact those, you can see the potential for ventricular pressures changing. So function-wise, as I said earlier on, we talked about the ECF environment of these, or interstitial environment, if you will, of these CNS cells themselves. And so it really is creating that equilibrium to provide nutrients in there. So it's no different than the interstitial space in a skeletal muscle or, extremity tissues. It's just that it got there through a different mechanism, which is this CSF pathway and subarachnoid space pathway. But the bottom line, besides providing the nutrients, also the metabolic waste. So you kind of go, yeah. But, your CNS cells have their metabolism, have their turnover, getting rid of their, microproteins, if you will, and you got to get them back into the venous system and, either recycled or excreted. And so, obviously, you need a healthy environment, CSF function to do so. But one of the thoughts is that, with aging, that the CSF function kind of diminishes. Flow, production, turnover, all those things diminish down, just like everything else, it seems like, with aging. But it might be the buildup of these wastes that maybe contribute more so to different neurodegenerative disorders, et cetera. So that's, one kind of clinical connection in there. Other functions, so again, these are a couple of talking points I wanted to add to. There's a lot of discussion in the neuro world about the CSF. Here we kind of look at it as a static, balloon bath for the brain, and maybe providing a quick conduit in and out of, nutrients and waste products. But there's a lot of discussion that there's actually a role as far as signaling CNS2 as well. And the CSF, as I said earlier, it gets absorbed throughout that whole pathway. It gets absorbed at, within the ventricular walls, but it also gets absorbed within the arachnoid space. And so some of the discussion is that areas, spellings, but some of the areas localized, it may talk to different spots or facilitate, I guess, some level of signaling too as well. So it isn't, just a static, H2O fluid, for lack of a better word, if you will. During growth, just like everything else, also has a huge role as far as CNS development. So again, any of the P disorders, for the obvious mechanical impairments they can cause as far as pressures and hydrocephalus and things. There's also issues as far as, development and allowing normal CNS development through the, early years. So that's a little overview as far as CSF function. And as I said, yes, it is the little cushion that the brain floats around in, so to speak. Couple fun facts as far as volume. Bottom line here is about 1/10 of a Coke bottle is floating around you at any given moment. The split up is a little bit variations, but sometimes they compare what's floating around in the brain versus spinal cord, or what's floating around in the ventricle versus subarachnoid space, a little different breakdown. But the bottom line is, if you total everything in the ventricles, total everything in the subarachnoid space, it's about a little over 1 to 2/10 of a Coke bottle, a liter bottle, if you will, of 150 mLs. Rate of formation, you go, okay, 20 mLs per hour, blah, 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 kind of do the math. Not so concerned about that number, but I sneak down to this number is each day those coracoid plexuses are cranking out about 5 or 6 milliliters a day. So you kind of look at the two, and it's pretty obvious this is way more than what's statically there at any given moment. So the real take-home message is, I probably would scratch that out and go 3 to 4 times per day. Again, I'm not going to quiz you at 3.7 versus 3.6, but the real take-home message is in a healthy individual, CSF fluid is turned over about 3 to 4 times a day. That's probably the long and short of it. And so the intention, obviously, is as nutrients are coming in, but as wastes are coming out, you need to get them out of there and keep that cycle going on and on. So I think this really highlights a little bit what I had alluded to earlier. As we said, with aging, it seems like everything kind of production-wise declines and recovery declines. But the bottom line is there is a certain amount of turnover slowdown with aging. And I would guess, I don't have the numbers, but again, probably one genetic family tree is more predisposed. How about that? Thank you. But to, whose family tree has a more impacting amount as far as slower turnover versus others that maybe maintain a longer term longevity. But the bottom line is, as that does, obviously you're not getting rid of what you need. And as I said earlier, the thought is, it's very multifactorial, but one of the key frontiers of research is looking at the role as far as how a buildup or a change or too much of these waste products could impact all of these DJD diseases we talk about, Alzheimer's and Parkinson's, et cetera. So that's fluid volume. Formation, as I alluded to earlier, those coracoid plexuses, these specialized cells within each of the ventricles, in the lateral ventricle, third ventricle, fourth ventricle, are essentially the production factory. But as I think I mentioned earlier, the brain has CSF fluid in it too, and it is crisscrossing paths along the ventricular walls. So there's some production or some, addition in that way. So it's a pretty dynamic process to get to the total volume, if you will. But at least half, if not more, is really produced, quote unquote, from the production factory piece of things. And if you think about it, you've got a blood supply coming to this coracoid plexus, an arterial supply that's giving this production factory what it needs to make CSF and the makeup of that CSF. So again, it's an interface of your blood equilibrium into your CSF equilibrium, if you will. All right, so again, as I said, this is just a nice visual to support. Usually it's in Netherland and all these neuroanatomy lands, the red always indicates the coracoid plexuses. But as we said, half of it's produced from these traditional spots, but anywhere along the ventricular walls, there's diffusion back in from the CNS itself into the ventricular space of CSF. So the pathway, I think we've really kind of gone through this. So again, lateral ventricle, 2 connections, third ventricle, downstairs into fourth ventricle, out it goes into the subarachnoid space. And as I said, there's really 3 little holes. There's one in the middle and then 2 on the right and the left in that fourth ventricle that allow the flow to occur. So way down here, you see the little arrow sneaking out. And again, that's the connection. So as it's produced, time-wise, if you were to run a tracer through there, you're guessing it's going to be somewhere between the 12 and 24-hour period of that turnover, if you will. But it's fairly predictable in terms of time. You can run the tracer through. follow it down. You start to see a little bit show up in the cervical spine after a half an hour, and then maybe an hour later it starts to show up in the T-spine and down further. And then you get up to 2 or 3 hours later, and eventually it's making its way back upstairs into the subarachnoid space of the skull, if you will. And then finally, eventually, whether it's 12 hours, 20 hours, whatever that individual little cell floated around, eventually it's going to make its way back into the dural sinuses, and out it goes into the venous system. So that's an overview. Again, you should just kind of recognize the hierarchy. And then again, we're back to our brainstem, but you can appreciate now a little bit more that midbrain syndrome blocking that off and wreaking havoc in a much more global way than just the midbrain itself. Fun facts. This is what I was referring to. You'll see a little variation with this, but the containment of between the ventricles and subarachnoid space of the brain, a little less than half, spinal cord, a little more than half. You certainly will see little variations between the two. The one number that seems to show up about is if you were to look at all the ventricular space, it's about a fourth of that total 150, give or take. So about 25% sits in the ventricles, and then the subarachnoid space and all, up and down is about 75% in any given moment in time. So absorption. As I said, the textbook discussion is this. Bless you. Textbook is gets back up to these subarachnoid villi and make their way back into the venous system. And for the most part, a lot of that is true. The only caveat is, and then I should also back up, don't forget there are, we focus on the arterial side penetrating and getting into the brain, but you do have the reverse. You do have capillaries leaving and venules, small veins, eventually making their way out and connecting to the venous system. So there is some drainage into those small capillary, venous capillary level blood vessels as well. But for the most part, a majority of it does do this. However, there are some other sites. And again, I just put this up to remind myself a little bit, just to pause and chat about it for a brief moment. The first one on the list is this cribriform plate. Remember I was kind of pointing to those cavernous sinuses, and I said we didn't have to name those, and I don't think I could name them either, and there's a pretty convoluted network around that pituitary and up near the chiasm and, the deeper part of the brain. But there's a lot of discussion as far as the area in that cribriform plate as far as absorption. And, you think clinically and ER-wise, the old CSF out of the nose and things like that probably makes sense a little bit to some degree. But the other side is down in the cord. You've got, at every single level of the cord, you've got a nerve root on both sides going from inside the pia, pushing out through all the layers and making their way out to the body as a spinal nerve root. And so in that area, too, is actually a potential site, and I think I did. This highlights that better. Also at this junction, too, there's potential site as far as that CSF getting into the bloodstream and those connections that way, too. So again, classically, yep, that arachnoid villi is kind of the majority, and that's what you'll read in most neuro textbooks. But appreciate there's a lot of discussion about some other areas, and I said cribriform plate and those dural sheaths of the spinal nerve roots are a couple other areas that are brought up. And you'll see a few more out there if you're really poking your nose into it. So that's reabsorption or absorption back into the venous system. And so again, it's really acting no different than a capillary mechanism. It's just that it's kind of taken this extra layer of mechanics to return. In other words, the capillaries are coming to the coracoid plexus. The capillaries are dumping fluid and whatever it can to produce a CSF So there's your capillary entry. The fluid flows through, and eventually, as it makes its way back, it is getting to the venous system. So this CSF thing does act as a junction between the two. It's just that it's a lot more gross in size and mechanics than a typical capillary area with interstitial fluid. All right, pressures, CSF pressures. Again, plunked a little highlights just as far as talking points. If you think about it, if the capillary network, remember you memorized, 190 arterioles, big drop down into capillary numbers. You start seeing numbers like 40, 30, 20, 10, then venous return back to the heart with those numbers around, single digits getting back to the heart of your venous system. Well, the CSF is essentially that venous capillary network, so it should make sense that it's somewhere around hovering around those single digits. The only catch is the flow has to go towards the venous system, so you want it to be more than those dural sinuses that it's flowing into. There's just a one-way valve, and if the pressure is pushing into it, if the gradient is appropriate, you have normal flow back into the venous system. So typical CSF pressures, high single digits, maybe early, 11s and 12s, if you will. But after that, you're going to start to have too much pressure and all the things we had chatted about clinically that can be a result of that. So this gradient has to be in this direction for healthy CSF flow to get back into the bloodstream. Those arachnoid villi, as I said earlier, essentially, I think the only take-home message I'd like you to appreciate is they are, as I said, a one-way valve. So you don't have backflow, but you either have flow or you just don't have any flow and you have congestive buildup. So it's not that that venous system is going backwards through that, door, if you will. So that's really the take-home message here. I'm not so worried that you memorize 1.5. This really just emphasizes the point that CSF needs to exceed, or that subarachnoid space has to exceed the venous to get the flow to go through it as it moves through. Downstairs here, a little discussion about ICP, intracranial pressure. So even with all these, if you've got a buildup of some kind of pathology or pressure, you could mechanically squish off CSF flow and have a problem, obviously. But the valves themselves really aren't influenced by that. In other words, if the fluid is at that arachnoid villi, even if you've got a pressure buildup, those valves are still able to operate. It's more the gross congested created somewhere else by the pathology that would cause your problem, if you will. So that's really the essential. So the moral of the story is, as ICP may fluctuates, it doesn't influence the passage of CSF into the venous system unless it's physically, grossly, blocked, if you will. So that's a little discussion as far as CSF pressures and normal pressures, as you look at things. CSF composition, as I said, I'm not sure if you did your LP lecture and, analysis, et cetera, and as far as its normals. But a few little talking points. Again, as usual, I defer to your clin med as far as your real threshold and breakdown as far as protocols. But this is more physiology talking points as far as differences. In general, a little bit higher elevation of CO2. We talked about the whole mechanism of signaling and hydrogen ions and CO2, as far as our pulmonary ventilation discussion. But higher CO2 values, 50 millimeters of mercury. Go way back when to your pulmonary lecture. Remember those numbers like 44 and those kinds of things. So that should, it's elevated. It's not doubled, but it's certainly elevated. pH, a little more acidic, not drastically, but just a tweak. Again, probably involved between that whole ventilation signaling mechanism that we had chatted about. But down here, definitely circle proteins. That blood-brain barrier is keeping those quote-unquote big honking protein molecules out of there. And, so you do an LP and there's a presence of, abnormal proteins, usually indicates some kind of, dysfunction or problem. Same thing with some of the other players that you would also find, again, your blood-brain barrier only wants to maintain a small amount of what's necessary and really keep away the fluctuations of your bloodstream out of there. Your CNS really needs to have kind of a narrow equilibrium of happy, healthy environment, if you will. And then chloride values, this might be a little bit of a white lie. Sodium, I think, is a little bit more in par, but, the real circle here is a lot of the transport that's going on to produce CSF and function, your sodium chloride balance between the two, those mechanisms are impacted. So chloride levels is the one that tends to be a little bit out of all the players, a little bit higher. Again, that's not intended to give you what your clinical lab threshold should be of what a normal LP looks like, but it's more kind of the conceptual balance or thought process behind it all. And then last but not least, there isn't a lymph system. Think about it. Lymph system in your body is the plumbing to take away interstitial fluid, if you will. Obviously, your blood vessels are dealing with, your plasma and your blood, but you have a cell and you have space in between it. That's your lymph system. In the CNS, we have a whole different version of things. You don't have lymph vessels penetrating in the brain to do it. So in a way, this CSF is fulfilling that role. And in fact, at some of those other spots, those dural sheath and that cribriform plate, the CSF is actually dumping into the lymph system in those areas. So, it's a specialized mechanism or function to try to do what the lymph system does, throughout the rest of your body. Blood-brain barrier, and really, as I said earlier, this is all about your pharmaceutical, and this is all about, we talked about neurodegenerative disorders, and this is a huge area or frontier as far as, preventing or containing neurodegenerative disorders. A lot of thought process is there's some dysfunction with the BBB that's allowed something to get in there that shouldn't, and that may be the trigger for the autoimmune. It may be the trigger for whatever pathology is being discussed, but that's where a lot of clinical research in the neuro world is looking at. And then the flip side of that, pharmaceutically, and I'm sure you've already addressed this in your pharm course, there are obviously different meds have different abilities to cross the blood-brain barrier, and their different clinical impact, et cetera, as far as their mechanism of action. So the blood-brain barrier, by definition, I'm kind of scanning down here what I have, but I think a simpler way is, again, you've got your CNS tissue, a brain and a spinal cord, but it needs blood vessels into it. Those blood vessels coming from the outside, and they travel along in that subarachnoid space. The arterial blood vessels do, and then they drop down and penetrate with their arterial blood vessels, smaller ones. And they kind of push through, and they're pushing through the pia, but eventually it penetrates, and it's directly a capillary or arterial capillary that's in the CNS itself. There's no pia between it and the brain. And it's the makeup of that capillary that, quote unquote, is your blood-brain barrier, if you will. Way back when, in lecture number 1 of this black hole of neuro, we talked about astrocytes, and they're kind of the glue, the connective tissue, makes up the physicalness of this thing. But these astrocytes are the ones that surround those blood vessels. They make up that, blood-brain barrier physically to, prevent things to go through. And again, that's where a lot of discussion is as far as autoimmune or neurodegenerative problems sit at that juncture, if you will. So the bottom line is, blood-brain barrier to keep things out it shouldn't, and just allow the CSF and that CNS environment to be what it is. As far as I said earlier, the coracoid capillaries, if you will, that coracoid plexuses have arteries coming in, supplying it, and then you've got a layer of coracoid cells, and that interface is the blood-brain barrier at those junctions. So that's what I was meaning by those coracoid plexuses are a site of this junction between what's coming from the blood and what's getting put into the CSF. But at other areas, obviously there's blood vessels outside those other areas along the way, these ependymal cells throughout the ventricles, etc. And it's the formation of that wall, the ventricular wall, that tightness also is creating a blood-brain barrier, if you will. So finally, I'm going to sneak down. This is just a schematic to appreciate the different sites, but I think I'll start with this one. This highlights what I was, again, this morning I feel like I'm kind of doing a mime thing with my hands or something, I don't know. But the point is, here's that subarachnoid space, here's that arterial system, and now you're going to penetrate into the brain. You want to get this blood downstairs to this cell. So these small vessels penetrating in, if you follow this, here's our pia that's getting pushed in and invaginated, but eventually you get to a place where it junctions and it stops, and these tiny capillary blood vessels are now the only thing between any of these CNS neurons or cell bodies. So the makeup of the astrocytes that are wrapping their little feet around this thing and surrounding these guys really make a physical, non-penetrating barrier, if you will. And again, that's referred to as the blood-brain barrier. Other sites, we talked about CSF absorption into the brain and out of the brain, but it's in this junction. There's little names, and there's this transition is a unique area that, again, in the neuro world gets a lot of discussion. But if you think about it, here's subarachnoid space and the potential for CSF to be exchanged at this transitional junction, and that's the thought of where CSF actually gets in to this ECF fluid of the brain, if you will. So pretty complicated areas as far as blood-brain in terms of different transition areas creating this barrier, pretty ingenious way to do so, but it's obviously pretty critical to keep this environment different from this environment, but to only take what you want out of that blood and make sure it's in the CNS for your core function. I thought that was just a nice artist's rendition of the capillary and those astrocytes, physically, literally making up that non-penetrating barrier. And I guess this is just one more artist's rendition of that. That just shows you nice 3D-ness of it all. Before we take our break, looking at this is our coracoid plexus, and it's, I was talking about it 2 or 3 times, but here's the production factory of these cells, specialized cells. Here's the interface of the blood stream. So that is getting put into the production factory as CSF is going, and also an exchange occurs. Further down the line, it's these junctions that are also creating a, blood-brain barrier. Really, it's a CSF brain barrier, if you will. So a pretty engineering challenge to separate these cells of the CNS from everything else, but a pretty amazing mechanism in of itself. All right, let's pause, 9 o'clock, and we will shift gears to the spinal cord for round 2.